thank you everyone for being here and welcome everybody. And today's workshop, as many of you know, is the second of the series for the hospital in transit, past, present, and future of the hospital ethnography, and in a global perspective. But it's organized within the format of these hospital ethnography peer meetings, which maybe some of you have already encountered, are an open space, but it's promoted by MICE, which is the Medical Anthropology Young Scholar Association. And within the MICE network, they created different kind of peer groups. And this is the one about hospital ethnography. So peer groups are supposed to be, first of all, a meeting space for young anthropologists and for exchanging ideas. And after a while, but we started discussions, there was this call for cases. And that was a way to talk practically from departing from ethnography and then discussing what problems we might have in common and how our daily practice as ethnographers is evolving and what are the problems that we face in a very comparative and informal discussion. So that's why we came up with these meetings, the hospital ethnography meetings. And this is the second out of 4. And the meetings want to be like a lively space of encounter, first of all. And to kickstart the discussion, I have invited 4 presenters that will present a case and their work. So there are going to be a 10-minute presentation for each one of these meetings. And yet again, this is the second one. So the next ones are going to be the 30th of October about the viral hospital. So it's going to be more about epidemics and the hospital and the intersection between these 2 topics. And the next one is going to be the 30th of November about hospital collaborations, well, hospitals as places that untangle different kind of collaborations, which could be both good and bad in many ways. So today I'm delighted to introduce 4 thought-provoking ethnographic case presentations. And the presenters will have, so that we are going to organize our workshop this way. So the presenter will have 10 minutes each to illustrate their ethnographic case and talk about their work. And then after each presentation, we're going to have 10 minutes of question or direct questions and a little bit of discussion. And after a short break, then we're going to have a collegial discussion so that we can actually have a more informal and more open discussion at the end. Do you have any questions, preliminary question, or we just jump into the presentation, which is the most interesting part, I would say? Okay. So I just leave the floor to Ronan.
Hello, everyone. Good morning, good afternoon, and good evening to anyone who's like around the world. Anyway, I'm presenting from Australia, and right now it's 1 a.m. in the morning. It's a bit late. Hopefully my story still make sense like that. So my research was about making hospitals in Tibet, and today I'm going to present a small section about COVID and doing hospital ethnography. Am I sharing the screen properly? Yes, good, thank you. So I conducted 2 years field work in 2 public hospitals in Tibet Autonomous Region, China, to figure out a puzzle, what factors result in the underperformance of medical professionals there and the state of China's great effort in investing in health sectors. The 2 hospitals are one Tibetan medical, the 2 hospitals are one People's Hospital specializing in biomedicine and one Tibetan medical hospital specializing in Tibetan medicine. Sorry, but that's the term in Tibetan. During the 2 years, they went through institutional changes from one People's Hospital to 2 hospitals, and then later formed into a loose assemblage called the Central Hospital. So the COVID-19 crisis impacted my research significantly. I remained in the hospital for a whole year since the lockdown in January 2020, and the pandemic, on the one hand, delayed my PhD research and writing process, but on the other hand, the time I had because of this crisis ended up deepening my understanding of the medical provision and medical practices there in the region. So on early January 2020, I went to visit my parents who live in inland China. I had been in the field for almost a year by then. I started in early 2019. I started to know what people would do on a daily basis. I could predict where and when to go find them, even if I hid in my pigeonhole room in the hospital where I was living. I was slightly tired of being in the fields. If it was not for COVID-19, my fieldwork might have been finished soon after the Tibetan New Year called Losar, which I was invited for. So I I went back to S County where I did my fieldwork. It was Yang, a temporary worker there in the hospitals. Her promise that she would take me home to celebrate Losar hooked me back. Losar was concurrent with Chinese Lunar New Year in 2020. That year, my role changed from a colleague or a professional to an anthropological fieldwork. I became an active observer that was aggressively interested in almost everything in people's lives. People's reaction towards my interests were contextualized and polarized. Some were annoyed, whereas others would be more interested in showing me their lives. Zhang Yang and some of her friends who were also temporary workers in Tibetan Medical Hospital will belong to the second group. When I was back, the pedestrian next to the hospitals was occupied by stray booths selling goods for celebrating Losar, such as Tibetan praying flags, homemade snacks, and yak butters, and so on. So I went hiking. During the time waiting, I went hiking on mountains with Kelsang. She is a Tibetan medical practitioner, and her 7-year-old daughter around the county town. I visited Padma's family residing in a nearby village, who is also a temporary worker. I mixed in Momo with other temporary workers' family, and I finally experienced my final loss after residing in 4 years in the region. I had no idea by then that I would be kept in the county for another year for the outbreak of COVID-19 as an expected event, and the lockdown it brought here by kept. I'm in a status of losing mobility, of being an outsider that must be held to a fixed place, of being a precarious situation that live under the kindness of my interlocutors. So in early February 2020, the early stage of the spread of COVID-19, the deputy mayor of S County's senior city holds an emergent teleconference facing all health workers there. I participated in this meeting in the governmental conference room with many managerial staff of the two hospitals. The mayor urged to combine practices of biomedicine and Tibetan medicine to fight against the newly emerging infectious disease. She repeated that no one is an outsider in the fight against COVID-19. Everyone in the room, including people from two hospitals, people from the Center of Disease Control and Prevention, staff of the Health Bureau, and directors from the township clinics, sat in the room solemnly taking notes. Unlike many other governmental meetings, no one played their phone in that meeting, but focused on the discussion of what they should do to cope with the crisis. When facing the local society during the time to cope with COVID-19 crisis, the hospitals and their staff worked as the tentacles of the governing apparatus. They govern the local community in the domain of healthcare service delivery, but also in the domain of social control. For instance, in terms of medical service delivery, the friction of the two hospitals had in their day-to-day practice due to the different medical systems they implement were rendered as merely technical in terms of treating patients and eliminating sufferings. Joint emergency simulation drills were performed once every couple of days to establish a standardized procedure and also to manage potential fever patients and to make up loopholes found in each drill. The drills were broadcasted on local TV news to the most remote valleys in S County, but Tibetan medicine, Tibetan medicine status has been acknowledged as displayed by the mayor in the aforementioned meeting also. So all staff in the Tibetan Medical Hospital spend days and nights making Napo Gujo, which is an amulet that was believed to prevent airborne disease by its fragrance. And they also made many other Tibetan medicines to distribute to the public. In terms of social control, the two hospitals were working as one work unit to perform joint social control tasks, in Chinese called Weiwen. This is to monitor local society by having staff on duty 24/7 and to participate in the county-wide joint prevention and control work in associate with the county's traffic department, the police department, the local township communities, and many other departments. As Danwei, which means work units, and especially public hospitals as they affiliated working units. The two hospitals govern and monitor the local communities. The two hospitals and their medical staff became the tangible ratification of the state power presenting in front of the people who reside at the remote countryside in the region. COVID-19 provides an excellent theme for the refining of the loose medical assemblage of the two hospitals into a medical apparatus. By medical apparatus, I mean that in S County Central Hospital, the aggregation of all health institutions and medical personnel there function as one institution, both physically and as a mechanism under the COVID crisis, with the power amplified beyond medical and healthcare sphere. In the everyday operation of the hospitals, a medical apparatus is in operation. That was medical professionals both providing medical care and administratively governing over the local society. Medical professionals play dual role of care provider and social monitor. This medical apparatus was amplified by COVID-19 crisis and the lockdown that resulted to manage this declared health crisis, what we might refer to as a state of exception in the words of Agamben. So the indication of doing hospital ethnographies during this COVID-19 crisis is as below. So when the news of COVID-19 was all over the social media, I was panicked as everyone. But one doctor's casual remark actually calmed me down. He said to me, "Those who swim in the river would not be drawn in the ditch." Medical professionals dealt with health crises often, that they believed that they would try their best to deal with this one, and they did. So before the crisis, I was more like a passive observer. I did my parts as a field worker, as an ethnographer, through engaging with people's public and private lives. But I lacked a deep understanding of medical professionals' perspective on their jobs, especially in terms of subjectivity and morality. Later, because of their solidarity in preventing COVID-19 entering the region, I wanted to contribute to their medical work beyond only helping with paperwork, which I used to do before the crisis. I participated the joint drill as a suspect patient several times. I helped with making Tibetan preventive medications and distributing them to the public. I covered for people who were unable to be on their administrative duties for personal affairs. I even participated in the black markets of tracing preventive amulets or surgical face masks. If there is a spectrum from outsider to insider as an ethnographer, I had been an outsider, then became an inside outsider, and more working towards an insider. All these works that I helped with made me a very, very participatory observer. But I was not always useful for the medical works in the hospitals, especially when people were busy with being engaged with their assigned tasks. I developed my own routine to take break. For instance, my basketball team made by the medical professionals was dismantled during lockdowns. So I jog regularly in the deserted county town. I also feel the minimal spare time I had due to people was occupied by their duties, with sorting out field notes and pictures, and then taking more notes. And I tried to learn the language better. I tried to use these activities to relax and taking my mind out of the field, even if I was physically in it. The field guided me to where I should be. Later, when lockdown was lifted in both Tibet Autonomous Region and in inland China, I was able to travel to inland briefly and went back to the Escante soon after. Because I feel attached there, I feel the COVID crisis hasn't done, and I feel like I should do more observation there and help more there. But by November 2020, I feel it's time to finally wrap up. So I packed up my luggage, moved away from the field in December. COVID-19 crisis was not over yet, but I need to write them down before I forget. So here's my acknowledgements and and thank you. Hopefully I could share any questions that you have to discuss further. Thank you.
Thank you very much. So let's open the ground for question. You don't need to write anything in the chat, just unmute yourself and ask the question directly. Thank you.
Yep, it's not a very theoretical discussion for the short time, the time limits, but feel free to ask me any questions you have.
Okay, actually, I have a question if nobody wants, so maybe they want to take a little bit of more time. Patricia, do you have a question first? No? Okay, I'll go and shoot my question instead. So I was thinking about how COVID-19 for you kind of opened up this space in which you became part of the team or part of the physician world and moral world. You talked about moral world in this particular sentence. And I was wondering about, was this because of the particular emergency state, exceptional state that COVID-19 represented? Because usually exceptional states are portrayed as a moment in which hierarchies, there is chaos, of course, but at the same time, hierarchies are tightened up. So in that sense, it's kind of, in a certain way, counterintuitive, the fact that you were able to be there because within this state of exception, let's call it Agamben, actually the hierarchies were loosened up. So there was actually space for you to, get inside and be recognized as a professional that is actually not usually part of the establishment of a hospital. What's your experience about this? What about hierarchies, how it changed?
Yeah, it's a really, really good question because sometimes I feel like a bit guilty for doing my research during COVID-19. I was like, okay, people are suffering. And I was suffer, of course, too. I was panicked when it first happening, but then I realized I'm a medical anthropologist. I got stuck in my field. Not many medical anthropologists had this chance, sort of like being stuck there during such a big event happening, like globally, impacts the globe. So I was like, I should do something. Maybe I'm not like a doctor to professionally help people by curing their disease or eliminate their suffering, but I could document stuff. And this is how, when I got stuck in this state of exception, and I found this new space that I might be able to contribute, at least to document what happened in a corner in the corner of the world in some medical institution that people having this effort actually dealing with it, which is like I found like echoing with a lot of medical anthropologists did during the period of time. But at the same time, I mean, it's Tibet autonomous region in China. It is always a state of exception. Actually, in my conclusion chapter of my PhD thesis, I sort of I conclude this as a dual state of exception. It's a state of exception that the government already implemented on this land and this group of people in terms of the sovereignty is always prioritized and the law is suspended, as Agamben's first illustrated. But at the same time, it is also a state of exception of because to dealing with this crisis, this health crisis, this medical crisis, everything else is suspended. Doesn't matter it was law or it was sovereignty. Everything like people's mobility, people's everyday life is suspended. So in that case, they already existed medical apparatus. That's the hospital, the medical staff, medical professionals. They play as, for Codian's perspectives, like governing the population, governing the individual body, but also sort of like being very explicitly displayed and directly displayed as they are actually monitoring the local community by joining the government's like joint prevention and control office to perform this administrative task. So this is what I feel like very essential in my field work, which helped me to understand the other than the wording, the understanding of their subjectivity, their understanding of the words through their subjectivity, but also their the tasks they carry on because the position sort of make part of their life, which make them make meaning or endorse meaning to their life during this period of time. Thank you. Hopefully this answer makes sense to you.
Yeah, certainly does. Thank you. Thank you so much. And I have Dennis on the list.
Hi, Dennis. You're muted.
Dennis,
You're
muted it.
Hello, everyone. Dennis Weidman from Florida International University in Miami, Florida. Rohan, a very good presentation and detailing your experiences in ethnography in two Chinese hospitals, Tibetan hospital. And the way you explain it is from your perspective and the way that you gathered the information and how you were integrated in the operations of the hospitals over a period of time. But in doing your ethnography, can you give us an example of where you were able to actually use the information that you gathered to then influence healthcare delivery? So in a sense, was there any actions taken from your work by improving the organization or the individual groups? This is a practicing kind of action anthropology question.
Yes, thank you very much for the question. So far, because I'm still in my writing up stage of the PhD, I haven't put it into applied anthropology's domain yet. But the general question of this research is to understand, okay, what's the biggest, what factors, what's the mechanism actually making people underperform, making medical personnel underperformed under the circumstances of Tibet in a Tibet autonomous region in China. And because I was working there for 3 years in international development in terms of house capacity building before my PhD started in 2018, so I knew that there's like great efforts in investing in infrastructures, in medical infrastructures there. But like we worked constantly developing on the capacity and people's initiatives on their working initiatives are not quite were not quite high, and it's still not quite high at the moment, I would say. So far, this research hasn't done anything that could be applied in the field yet, but like later I would hope that by publication with certain chapters that I developed during the whole writing process could have some indications in terms of providing solutions to let's say house reform impact in remote rural or suburban health institutions, or in terms of like understanding why people working in remote institutions has low working incentives. Thank you.
Thank you so much. Thank you so much. So do we have another quick question? I think we have time for one question more, then we have to move on. Okay, thank you so much again, Ron. And thank you again also for the late hour you're in right now. Thank you.
It is pretty late. I was like, I finished my task.
Thank you again.
If I disappear later, please excuse me, because it's 1:30 a.m. now.
If you want to leave your email maybe in the chat, if somebody has maybe a later question, that would be great to get in contact. Thank you again.
Yes.
Thank you. So thank you. So Hanum, it's next.
Okay. Can I share my screen? Yeah. Perfect. Does that work, or is it like a presenter?
No, it's perfect.
No. Yeah. Yeah. All right. Perfect. Okay. Thanks very much. Okay. Good afternoon, evening, and good morning, everyone. I'm joining here from Indonesia. I'm currently still on my field work. And thanks, Mirko, for organizing the workshop today. I really appreciate that. And today I would like to share my reflection on my 8-month ethnographic fieldwork in Indonesia last year in 2020. It is on waiting and navigating access in hospital ethnography. So my research was part of the Globalizing Palliative Care Project, a multi-sided ethnographic study of practices, policies, and discourse of care at the end of life. This project has been funded by the European Research Council and hosted by Leiden University. So my research focuses on how women with reproductive cancer and their caregivers navigate their cancer care trajectory in Indonesia. And one of my research settings was at the cancer hospital in Jakarta, Indonesia. Here you see the dot, the red dot. That's the location of the city or the province of Jakarta, and that's also where the cancer hospital where I did my research was. So this hospital was a referral hospital for patients across Indonesia because there's still limited cancer care facilities across Indonesia. So when I conducted this research, there was still some restrictions in conducting research at the hospital due to COVID-19 pandemic. However, I got a permission to do research at the hospital, but there's some restriction what I can do, where I can go, whom I can talk to. So at that time, I could talk to the caregivers, but also the health workers. And I did some participant observation at the palliative care unit, but also at the waiting room. And this presentation, I will focus on waiting as a way to methodologically address navigating hospital structures and access. And I'm going to tell a story, a case study. It's a story of my participant, whom I call Rika. It's a pseudonym, and I'm going to just tell you the story. It was the end of April 2022. Dodi and I were sitting together at the corner of the ICU waiting room in the cancer hospital. And this corner had been a temporary place for him to stay while he had been waiting alone for his daughter, Rika. Near his chair, his big backpack with a small pillow on top and silver thermos in the pocket hinted at his long stay in the waiting room. And he told me that he couldn't leave Rika alone because sometimes the nurses or the doctors call him. 32-year-old Rika had been in the ICU for almost 2 weeks. But he and Dodi stayed in Jakarta for about a month already, pursuing treatment for her advanced cervical cancer. So she was diagnosed with a stage 3B cervical cancer. Dodi and Rika flew to Jakarta from their hometown in Kalimantan to pursue advanced cancer treatment due to the lack of cancer care services in their hometown. In one of our many conversations, Dodi told me about Rika and his experience and challenges in navigating the care trajectories at the hospital in the Indonesian capital. As I visited Dodi multiple times, I also started getting to know people in the ICU waiting room. It was because Dodi introduced me to the people around him when I visited him. And these caregivers were also waiting for their family members who were lying at the ICU room. Some of them also told me a story of their trajectories and the challenges while staying in Jakarta, far away from their hometown. They shared with me their hope, frustration, and also their fear. For them, it was often uncertain about when the treatment journey in the referral place will end. And after multiple visits and observation in the ICU waiting room, I noticed that Dodi and other caregivers had also formed such a sociality. Caregivers who were staying for a long period in the waiting room to accompany a patient and can create a platform for in-depth relationships and enhance relationality among caregivers to navigate the hospital structures. So when I conducted my research last year, only one family member or caregiver was allowed to accompany patient in the ICU waiting room because, again, there's still some hospital restriction at that time. Thus, despite being a carer for the patient, the caregivers also cared for each other. And then when the caregiver had to leave the hospital, for example, when they had to do mandatory COVID-19 tests at that time, or when they had to buy something at the supermarket, they asked for the others to watch on the patient. Sometimes they also share food and hygiene supplies for the patient that were not covered by the national health insurance. Moreover, caregivers in the waiting room often share information and learn from each other about the treatment pathways, the insurance system, and the online system at the hospital, which for them it's quite unfamiliar. One day, Rika's condition was worsening. She needed a blood transfusion, and the nurse asked Dodi to find a blood donor. And since Dodi didn't know anyone in Jakarta, caregivers in the waiting room helped Dodi to find blood donors for Rika. Luckily, one of the caregivers can invite his friends who lived in Jakarta to donate blood for Rika. So the story that I've just told you shows that waiting is more than just a passive action. it is not just an empty time of sitting still or being in a limbo. However, it is instead of an active movement. During the waiting period, caregivers are also still navigating the hospital structures. Waiting, particularly for the patient with a critical condition in the ICU, has a positive and negative effect on the caregivers, such as hope and fear, anticipation, and resentment. So what does waiting means for research? So conducting research in the hospital waiting room as a semi-public and social space can allow the hospital ethnographer to be involved in the relationality among caregivers. As I'm waiting with Dodi and other caregivers in the ICU waiting room, I have also learned from the experience about hospital structures and how to navigate a complex hospital system. However, conducting hospital ethnography in the hospital waiting room, particularly in the ICU waiting room, may also have limitation regarding the participation. As the essence of waiting period is often uncertain and unpredictable, it can be challenging regarding the continuity of the participation in the research. So both researcher and participant often do not know when the waiting will end, and suddenly waiting can end. Thank you very much.
Thank you. Thank you very much. Thank you again. And okay, so let's just open the floor for questions.
I would like to speak up.
Yeah.
Thank you
Go ahead,
very much.
Margaret.
This was very insightful, and I've done research in waiting rooms, so I feel connected. That's new for me that an ICU has a waiting room, and I wonder if the hospital uses this very special place to offer information to the people who wait, like putting out their health information via screens or via leaflets, or I don't know anything about Indonesia, I'm sorry, if a social worker comes around, or is this any way used? Because it's something that I would be curious about, because they are doing this in Austria now. Thank you very much.
Oh, thanks very much. Thanks very much for the question. Yeah, so the ICU indeed they have a waiting room, but usually it's like a usual waiting room, but it's just a room with lots of chairs and regarding the information, there's like no leaflets or no brochure or nothing about that. Usually the nurse, they ask the nurse, and it's just not lots of information, and the customer service, it's like for the general customer service. And in Indonesia, the profession of social workers is not it's not very well known, in a way that there's still like no social support and also like other type of support, like psychologists and stuff. So it's very much limited in terms of social support. And yeah, so the thing is that this is a referral hospital, and people are not very familiar, not let alone the not familiar with the city, let alone the hospital. So there's a lot of confusion where they should find like well, medical supplies and stuff like that. And what interesting part is about the blood donor, because we have like a blood bank, but sometimes still the family members was still asked by the hospital, like, oh yeah, well, we run out of stocks, so can you find relatives or anyone who can donate blood? And yeah, it was quite yeah, stressful situation at that time. So yeah.
Thank you very much.
Okay, other questions? Okay, then I'll just go ahead and ask you, Hanum. And thank you for your reflection about waiting. And it actually made me think about my own kind of experience about waiting. And I have been partially doing ethnography inside a waiting room in an emergency room. And of course, there was, this problem about information. And what I've been always struggling with is when you wait with patients, and I wonder what's your experience about this, which kind of role could you craft for yourself? Which kind of role could you have while you wait with them? Because, to create a role as not only an observer, but also a participatory observer, while you're waiting with them, you're also shielded from what actually happens inside. So you're always kind of in between. And I don't know about you, but what I have experienced about, I was always worried about what was happening inside, what I was missing as an ethnographer, but also what these people actually didn't know and how I could be helpful with that. So how I could be kind of the link between the inside and the outside in this sense, and how to negotiate that in order also not to cross the healthcare staff, because of course, if you provide a different kind of service, they would ask you, okay, why you're doing that. So what's your experience about navigating a particular role of being in between waiting and the inner side of the ward?
Yeah. Oh, thanks very much for the question. Yeah, because at that time I was very clear that I'm a researcher here. I'm interested to your experience, but also I did my participant observation specifically at the palliative care unit. So sometimes my role is actually if they kind of like confuse or has questions regarding the hospital, I kind of like bridge that information by asking the colleagues at the palliative care unit, because they're familiar with that kind of system. But also, I don't know with your experience, Mirko, but when they wait, like I remember one of my participants mentioned that to me, but I'm here alone, like no one visited me, and you come here, I just need someone else to talk to apart from these people around me here. So it gives them kind of like the fresh, I'm not giving them insight or anything, but like someone else to talk to and then to listen to the experience. And for me, well, it's very rewarding as well, but also give a lot of rich information. And yeah, just like to talk to someone that are not related to you. Sometimes they couldn't talk to their family members who live far away, who doesn't really know about the situation, what's been going on. So yeah, it's as an ethnographer at that time, when I did my research at the waiting room, it at some point it's beneficial, but also like you wait because you're waiting with them, and the relationship that I built with them, like because I knew them from the house where they stay, but I also did my research. So that kind of relation already formed, but also it kind of like, yeah, at the end you wait for them, for the patient as well. So yeah, it's give you kind of like mixed feeling, I would say. Happy, but also
I truly imagine that also being in a particular setting like an ICU, I imagine it to be even more particularly challenging in that sense. So thank you for.
Indeed. Yeah, and especially with the uncertainty, that's something that just gives some sometimes upsetting feelings as well. So,
okay, thank you so much again, and also just a very quick curiosity, if nobody would jump in with new questions. Did you have also problems in relation to, because it's an ICU, which kind of information you should give, which kind of information maybe you learned from the inside of the ICU but couldn't share? So the management of information was particularly problematic within this kind of research setting, staying in the waiting area?
Yeah, you mean the information that they share with me, and then as a
Right.
Yeah. So because at that time I positioned myself as not as a hospital staff. I made it clear that I'm not a health worker here. I'm not working here. I'm just a researcher. So just be clear that what they share with me, I will not share any cases with the health workers or with the hospital workers, not only health workers. So just make it clear that what they share, it's for the research, and I don't. And with the health workers, I don't share cases from the participants. So kind of like make it clear, and to just to avoid that kind of clash or misunderstanding or problem later on.
Thank you so much for this. So we have time for a very last question, a very quick question. If you have any, otherwise we just go ahead and leave room for the final discussion. Okay, so thank you again, Hanum, for your great presentation. And now it's Dr. Kalindi Sharma. You're up next.
Good evening. Good evening, everyone. Marco, am I audible? Okay, thank you so much. Good evening, everyone. It's close to 8:30 in India. So, all right. I think my screen is visible as well. Okay, okay. So thank you to the organizers for providing me this opportunity to present my work on cultural phlenicism, reading the politics and strategies of a mental health clinic in South Asia. I'm currently employed as an assistant professor of social and cultural anthropology at the Department of Human Behavior, which is a tertiary hospital, neuropsychiatric hospital, and an Institute of Human Behavior and Life Sciences. And it's got a bit of a problematic history. During the course of the paper, I'm going to discuss that. So let me just begin the paper. So the paper explores, I don't have a presentation, so I've just got a picture because there are various protocols that I need to follow in order to share the pictures, because it's, as you can understand, it was once upon a time a mental asylum, so the data is quite sensitive. So there are a few pictures on the public forum, and I'm sharing just the building of the hospital. And I just want to tell you that it kind of follows the panopticon structure that was discussed by Michel Foucault on the insides. Anyway, so the paper explores the concept of clinic that is situated at a neuropsychiatric hospital as a space for a dynamic exchange between patients and a team of experts that comprises of not just medical practitioners or clinicians with a license by the MCI. The MCI is the Medical Council of India, which is the authority when it comes to licensing the medical practitioners to diagnose the ailment and recommend drugs. But there's also a team that accompanies these medical practitioners that comprises of a clinical psychologist, a psychiatric social worker, medical anthropologist, and sometimes a social and cultural anthropologist as well. I represent the Department of Human Behavior, which is a newly established department. It was established with my appointment and the appointment of 2 other assistant professors from clinical psychology as well as psychiatric social work. So we accompany this team during the grand rounds and the medical rounds, and our department has also initiated a new non-clinical OPD in the hospital, where we deal with patients with non-medical ailments or ailments that would not have any kind of administration of drugs to begin with. So the panel of experts also sometimes tends to include epidemiologists and biostatisticians who share their insights about the ways in which cases may be approached when we are trying to understand how these cases may be a result of, say, long-term community exposure to a particular kind of concerns, social concerns or social problems that are common in an area. It could be long-term conflict exposure, it could be just regional exposure to some kind of epidemic, and so on. So there is always a team of people specializing in multidisciplinary domains that share their insights at the hospital. It's a tertiary hospital. That means it's a super specialized hospital. So in this paper, which is based on my preliminary understanding of conducting hospital ethnography at the clinic as well as at the OPD, I link the birth of the clinic as foregrounded by Michel Foucault, that is a space for understanding and analyzing human behavior, manifesting debates of normalcy and abnormality, reason and lack of reason, as well as sedition and blasphemy, things that are all the rage in India right now. Teaching hospitals like IBAS being the acronym for the institute, are not novel establishments. Rather, they have been a space of inquiry in Europe since the 18th century to cater to the mentally ill patients and with the aim of providing custodial care to Englishmen and Indian soldiers engaged in the service of East India Company. The company established a series of mental asylums. The first asylum that was set up in India was in Bombay in 1745, followed by one in Calcutta, currently known as Kolkata, in 1784. That began with the idea of serving people with war neurosis. It was followed by one more mental asylum that was set up in a state in India, in I would say somewhat eastern part of India, in Bihar, in 1795. Now, most of the mental health institutions that we are familiar with today have been relocated or rechristened, owing to a long-drawn battle to destigmatize concerns regarding mental health and psychosocial well-being of individuals. Even this institution, which I represent, that is IBAS, that is Institute of Human Behavior and Life Sciences, it was initially known as HMD, or the Hospital for Mental Diseases, Shadra. It was the precursor of IBAS that was established in 1966, and the hospital wasn't free from the colonial hangover of treating individuals with mental health concerns in a closed custodial setting. The patients were housed in closed cells that were enclosed within the high walls of HMD, and the hospital currently has those ruins only for the purpose of showing the difference in the architecture from the past to the contemporary times. We still have those ruins. From time to time, when we have students, visitors, who would like to see how the hospital has changed, we show them those buildings and we try to tell them how the earlier structure was more cellular and more cell-like, and had the intent of isolating the patients to a more inclusive space at the institute. The patients were obviously dealt with aggressively and in a manner that was very punitive, violent, and beyond the realms of what may be considered as humane. It was in 1983 that a public interest litigation was filed at the Honorable Supreme Court of India, where it was decided and orders were issued for the remodeling of the hospital as a center for treatment, training, and research. HMD was now registered as IBAS in 1991 under the Society Registration Act of 1860. Through the means of discourse analysis and hospital ethnography, I intend to explore the space of the clinic as one of cultural pluralism, inclusivity, and psychosocial well-being in terms of the medical gaze towards the patients. Historically, this medical gaze has been the loci of establishing governance and dominance over people, their bodies, sexuality, gender, and even the rationality of what comprises of disease and contagion. I bring forth the notion of cultural clinicism that reads the unique role of mental health clinics in South Asia that is embedded with territorial conflicts, communal tension, caste-based violence, post-migration, insurgency, and many such social problems that are continuously responsible for trauma and mental health concerns. Through the means of this detailed hospital ethnography, I also intend to foreground the debates regarding the changing role of clinics as a medical public space, and I intend to challenge the hegemony of medical practitioners over allied disciplines working at EBAS, their cultural competence, specifically the cultural competence of the medical and the paramedical staff that lead to the modernization of the metaphor of the clinic. I, as an anthropologist, act like a shadow observer in few cases of psychological non-medicine intervention. I have witnessed the shifting of the medical gaze that does not remain confined to signs, symptoms, time and space, but this gaze begins to encompass the notions of deviance, established norms of behavior, the abstract and varied understanding of the domain of psychosocial well-being as perceived by each member of the team I mentioned earlier. The clinic becomes a social space that is bereft of a limited understanding of being a sanitized pathological space. It is within this social space of the clinic I have witnessed the blurring of the boundaries of what may be considered as ethical by clinicians, the normal and the abnormal as understood within the socio-cultural matrix of the patient as perceived by the clinician or the therapist, where the therapist or clinician who's not an anthropologist is constantly negotiating with the complex interface between the patient and themselves as members of a society, a religious of being of a particular religious background or belonging to a specific caste group and so on. Foucault stated that disease and pathology are elements of the visible. But in a tertiary care teaching hospital like EBAS, this medical case is constantly redefined by the vagaries of psychiatric illnesses or psychological or behavioral deviance, and the distinct and yet divergent gaze of the clinicians as a social being. As a hospital ethnographer, I must mention that my gaze is that of a silent one. It is a silent gaze that aspires to look beyond the expressible symptoms of the patients or seekers of intervention. As an anthropologist, there are times when I'm sitting at the OPD accompanying my fellow clinicians and fellow team members. And when the patient walks in, there are times when I am actually questioning whether this person, whether this individual actually qualifies as quote unquote a patient. So many a times I end up demedicalizing their conditions and attributing their symptoms to more cultural, social and cultural factors that are at interplay. And I attribute it to their lived experiences and the socio-cultural position of the patients. Over the time, it's been, I think, 2 to 3 months since we opened the OPD, which is non-clinical in nature. We have had quite a few patients. And as I told you, the team comprises of people representing various disciplines. I've had to debate with each one of them about the significance of ethics, how they deal with the patients, what is it that each one of them considers as confidential, what is it that they consider as ethical, what is it that they consider as worthy of sharing, what part of the identity of the patient are they willing to share when they are discussing the case among themselves? Is it the registration number at the clinic? Or is it the name of the individual? Is it the gender? What kind of negotiations are going on? And over the course of this initiation, as an anthropologist into this mental hospital, I have also had to face a significant amount of opposition from medical practitioners who have this natural tendency of creating a hierarchy of things that may be considered as tangible outcome and the role of an anthropologist and how do they contribute to patient care. So it's taken me, it's a long journey, as I foresee for myself, because I'm a regular tenured faculty over there, and most of the students that would eventually come to us would be doctors, and these medical practitioners are trained to believe that they are not just, at least in India, they are not just representing a noble profession, but they are akin to God because they are saviors of life. So coming down, descending from that supra status and talking to us, lesser mortals like anthropologists, has been quite the challenge. And every day it's been like breaking barriers. So it has been quite an interesting experience over 2-3 months. Sharing my insights with them, observing them as silent shadow observer, looking at how the biases of community, how their inherent religious biases operate while they interact with the patients. There are times when I just make notes sitting in the clinic, knowing whether, and I always face this dilemma of whether I should tell them that what the patient is reporting is essentially part of their culture and not a medical concern. And it is something which may be considered as normative in their community. And India being such a diverse nation, it is very important for us to sort of train the doctors in being more competent about their awareness and consciousness with regard to the community. So I'll keep my presentation very brief. I hope, because I'm in the process of collecting more cases, I still need some ethical clearance to be able to share the cases in detail. But this is the preliminary work, and I propose the idea of cultural clinicism just to explain how the notion of clinic is being reconfigured on a day-to-day basis when we look at the multidisciplinary approach to the clinics and the medical gaze, how it is being redefined in a mental hospital or an institution that caters to psychoneurotic patients visiting there. Thank you.
Thank you so much. That was really great. And thank you. So, okay. So let's gather some questions. Do we have some immediate questions for Dr. Kalinda Sharma?
Hi, I would like to ask you, actually, thank you for this wonderful, it should be your role there, because Patricia Huddleston in the University Hospital of Geneva, who is with us at the moment, who does cultural consultations, who has a clear role, and where people come and ask for intervention when they are having troubles. I wonder, what's your role in there, or are you only there for research, and is it not applied? Thank you for clarifying.
Okay. Thank you for your question, Margaret. So as I informed earlier, the Department of Human Behavior was established with our appointment, and it is envisioned that the department will eventually be more involved with community outreach activities. And the idea behind setting up such a department is that one of our mandates was to not just understand deviant behavior, because this is something which the clinical psychologists, psychiatric social workers, psychiatrists, and neurologists are already engaged with. So the purpose, and we already had a medical anthropologist working there. So the purpose of appointing and recruiting a social and cultural anthropologist was to understand the aspects that may be considered as normative in communities and not exactly non-normative, and that which can be considered as normal and non-deviant. So it's my role is currently to not just restrict myself in research, but to be a shadow observer in all the cases other than the ones that may have some litigious matters associated with them. Other than those matters, I am currently completely engaged with being a shadow observer for all the cases of psychiatry and neurology, and also the cases that are non in the category of being prescribed medicines. So we have still not begun with the stage of consultation, cultural consultation, because as I'm telling you, there's a lot of hindrance, and there's still a lot of resistance among the medical practitioners of, and the reason for that is we have the residents, the senior and the junior residents, that are not permanently recruited. They keep coming from general hospitals. So they are not sensitized to the role of an institution that deals with psychosocial well-being of individuals. And therefore, the first step that we would be focusing on is developing a degree of cultural competence among the residents that would be visiting. So even before providing consultation to the patients and their attendants, it's more important for us to develop a level of sensitivity among the hospital staff, the medical and the paramedical staff, when it comes to the ones that are more I would say temporary and contractual compared to the permanently recruited, because they are already very empathetic towards the patients and they already understand the nuances of psychosocial well-being. And from time to time, the nurses and the paramedical staff is being trained and workshops are being organized. But when it comes to actual medical practitioners, they are being employed on a rotation basis, and therefore their resistance is more towards social scientists, and they have a tendency of considering anthropologists, clinical psychologists, sociologists as one monolith, which is quite the challenge for us to negotiate with. So I'm talking about the initial boundaries that I have to break, the ice-breaking sessions that I have to have with the with the medical practitioners, the doctors per se, before I venture into training and sensitizing the patients and other members of the hospital.
Thank you so much. And we have another question immediately after. So Dennis? Dennis, I think you're muted. Yeah.
It would be very fine. To be so engaged in the clinical setting and clinical care, it's a fine example of what we've been calling for generations, clinical anthropology. I myself, back in the 90s, was actually a unit director of a mental health clinic, outpatient. And so I was an anthropologist, but also a decision maker and a manager of the actual care provided by social workers and psychiatrists. And so I relate to what you're doing. It's to be in your role. I honor you for continuing that tradition in anthropology to carry us forth. Right towards the end, you mentioned an interesting idea, but you just kind of glanced at it and you said cultural clinicism. Cultural clinicism. Did I hear you right? And what does that mean?
Yes. So this is the concept that I'm working on, the idea of cultural clinicism, which is redefining the space of the clinic as a more culturally inclusive space, but a space where the distinct boundaries of culture are constantly operating when there is a deep patient and doctor-patient interaction in that is in progress. And this is something which, as an anthropologist, I've been observing that the medical practitioners are not really conscious about. And as I did give a very small example of the times when I'm just sitting like an observer, and I see a clinical psychologist talking to a patient, and that patient could be suffering from, say, paranoia, and this paranoia may have some specific kind of behavior, components of behavior that I can, as an anthropologist, quickly deduce as something which is a common occurrence in a particular community. However, for the clinical psychologist who may not be of the region, it is very difficult to understand and relate to. So this is the idea, the cultural clinicism idea is what I'm talking about, what I'm working on through my hospital ethnography. I'm using cases to qualify this notion of cultural clinicism, to explain how clinic is not just a sanitized pathological space where we are talking about symptoms and ailments, and diagnosis, but we are also talking about how these ailments could be situated in the cultural upbringing of an individual, and how there is a gap between this patient and the doctor, and how this gap can be better bridged if we are able to deduce the differences in the culture, and if we are able to sensitize individuals involved in this interface towards a more culturally inclusive understanding.
All right. I might bring up the history of medical anthropology. When it was the Society for Medical Anthropology, founded in the 1970s, Hazel Weidman was a major contributor to that. And she established clinics at our hospital here in Miami, which led to a foundation for the development of medical anthropology. She had a concept of culture broker, that the anthropologist then becomes a culture broker between the biomedical system and the local multiple pluralistic cultures of the patients.
Yes.
And so that's what she put me in that role. And so I was the director of this clinic, and I was the culture broker. That's how she envisioned that. Does that fit with what you're trying to do?
So the concept of the cultural broker is when the role of the anthropologist is clear. As I'm telling you, one of the challenges of my role as an anthropologist in this institution is to constantly negotiate with the resistance that and this begins from the top of the hierarchy to the lowest rung in the hierarchy, where I have to constantly tell what my role is. So when you're talking about the notion of cultural broker, as you're saying that you were already attributed this role, that only goes to say that the individuals involved were clear about what you had to do, your role as a cultural translator. However, when I'm talking about the space of the clinic, I'm talking about not just my role as an anthropologist, but I'm talking about sensitizing individuals, even in my absence, individuals being able to understand, be it the doctor or the patient, being able to understand and communicate in a more effective manner, and viewing the clinic as not a space separate from the society, but the situation of the clinic needs to be understood as well. The location of the clinic needs to be understood as well. So it's a whole like the location of this particular hospital that I'm talking about is in an extremely populated area of Delhi, which is the national capital, but it is the boundary of two states. And it is, you could say, a location itself is amidst the minority communities of Delhi and India, and therefore this hospital has been pretty much relegated to the margins as a place of criminal activities and so on and so forth. So the location of the hospital, the location of the clinic is also something that plays out in terms of the frequency of patients and the kind of patients that we get over there, and how they are met with biases when we talk about the medical practitioners that come to that are appointed at the hospital for a temporary duration. So I'm talking about not just my role as an anthropologist, but I'm talking about how the location of the clinic also needs to be understood against the larger socio-cultural context of where it is situated and how it is being viewed by every individual, every stakeholder.
Excellent. You're making a major contribution. Thank you so much.
Thank you.
Thank you so much again, and thank you again for your great presentation. And I am afraid we have to, maybe we have one last question, very quick one. No, okay. So I think we're gonna move on. Thank you again. And so the next presenters are Anna and Carolina.
Hello. Sorry. Let me. Can everyone hear me right?
Yep.
Okay. Let me just share my slides. Okay. A second. Okay. So can everyone see slides? Okay. Great. Thank you. So thank you for that introduction. I'll be the one delivering this presentation. This reflection stems from a research project that we are carrying out together as a team with my colleague Carolina. I think she's online right now. At the Autonomous University of Barcelona. Although for the purposes of this presentation, we have decided to focus on the field notes from just one of us. So just to give you a little bit more context about our research project, this research aims to explore the experiences of pregnant patients who have been screened with a high risk of preeclampsia, which is one of the most prevalent complications during pregnancy. So we've been conducting fieldwork this is ongoing research. We are conducting fieldwork at a public maternity hospital located in a mid-sized Spanish capital called Murcia. And this involved observations in pregnancy care, ultrasound consultation rooms, specialized consultation areas for pregnancy pathologies, the obstetric ER, and some other relevant areas within the hospital. So during this fieldwork, at this regional public maternity hospital, particularly when witnessing some critical, intimate, and emotionally charged moments, I've experienced moments of emotional overlap, as described by Felmon and Mendash, or revelatory moments in terms of Paves. These are specific situations where ethnographer and participants share intense emotional vulnerability. So some scholars argue that these instances are key to achieving thick description as they blur the boundaries between the observer and the observed. So in this maternity hospital, as I was both witnessing and experiencing in my own body those shared moments of joy, pain, fear, grief, hope, I was faced with an interesting opportunity for methodological reflection. So as I went through my fieldwork diary and read my notes, I noticed how I was trying to sort out all these emotions to find the actual ethnographic data. However, in the process, I found that emotion and affect were inextricably linked to the actual lived experiences in the field. Therefore, I asked myself, isn't this maybe precisely what I was looking for? If we consider ethnographic data from the relational and emotional point of view, and as a result of the interactions between ethnographer and participants, how should we then collect, process, and analyze this kind of data? So I wanted to illustrate this train of thought with examples from my own field notes. So quick content warning for those listening. In this ethnographic vignette, I describe the moment of diagnosis of a pregnancy loss. So before I proceed, I wanted to encourage all of you to take care of yourselves as you choose to listen to this. And I ask organizers to let people in and out during the next couple of minutes, if that's okay. So for context, this happened during a twin pregnancy specialist consultation. The patient was 25 weeks along with monochorionic twin boys, and she came to the consultation with her husband. So this is what I wrote in my field diary. I'll read it out to you. So during the abdominal ultrasound, the doctor asks, was everything all right 2 weeks ago? The patient answers, yes. The doctor pauses for a few seconds while continuing to look at the screen. Without taking her eyes off the ultrasound, she says, it's just that one of them has lost his heartbeat. She says it like that, in one sentence. I am very shocked by the way she says it without any ado. The patients cry, scream, they ask why. Suddenly, a lot of things happen very quickly. The atmosphere in the ward and even in the hallway immediately shifts. It's almost like the air becomes heavy. The doctor asks the medical student and me to go get another doctor. I take the opportunity to leave and wait in the hallway as I now feel like I shouldn't be there. The nursing assistants ask me what happened. Then one of them says, I recognize those cries. So something I learned from this passage in my field diary is that certain experiences in the field could never be captured in an audio or video recording, for example, and barely in writing. The way I felt the air becoming heavy, that heartbreaking sense of loss that we all shared, that's information that can really only be gathered through empathy, by committing in a sensory and emotional way to the scene, and by letting others' sorrow physically pass through us. To be honest, my memories of this scene are tunnel visioned. Since then, I've been able to ask myself some more questions, such as why the doctor reacted by asking us to leave the room. Did she perceive this moment as intimate and wanted to give the patients some space? Did she want to give us the opportunity to remove ourselves from the situation if we were overwhelmed? Did she feel uncomfortable about being watched at this critical moment in her practice? Did she actually need another physician? Sadly, I don't think we'll ever know. For now, these are just hypotheses and questions emerging from a retrospective reading of very chaotic field notes. What I do know is that I felt overwhelmed. I didn't ask questions and just left and reached for shelter with the nursing assistants. And it was then very difficult to face the task of writing. And it is still difficult to go back to that moment. Even if this was, of course, not my loss, and I had never been in a similar situation before personally, I felt unexpectedly connected to these parents, and the memory of their pain stayed with me for the next few weeks. So I chose an evocative, affected writing style because I realized that I could only properly describe this moment through my own heartbreak, as it was not actually mine, but rather shared by everyone involved in the scene that day. So for some final thoughts, there is considerable literature supporting the analytical potential of emotions in ethnography and their value as very real ethnographic data, yet maybe not as much exploring the added nuances in hospital qualitative research context. Following the legacy of the affective turn in social sciences, we can see how emotional reflexivity was central to this data collection task. And I argue that this is a necessary form of emotional labor that enables a more honest analysis in ethnography. As you all probably know, hospital ethnographies often require the effort of confronting and processing human suffering as part of the field experience. This is yet another form of emotional labor that ethnographers engage in, which, as discussed earlier, is essential for thick description and rigorous research, but it is not without challenges. As ethnographers, we should develop methodological approaches that embrace emotions and affect as ways to understand human experiences, but we also need to consider strategies for coping with emotions in the field. In conclusion, emotions are complex pieces of information. They are not just part of an ethnographer's personal experience, but an inherent part of social life and ethnographic data that can provide significant insight when systematically analyzed, precisely because of how they live right at the intersection between our fieldwork and our intimate lives, between the public and private access of our humanity. So this wraps up this presentation. Thank you very much for listening, and thank you to the organizers and the rest of the speakers for this workshop. I'll let you take it up with questions.
Thank you so much, Anna. That was great, and thank you. Okay, Margaret, do you want to jump up with a question? I saw you had a comment in the chat.
Thank you very much. This is so important, and we are still the ones who are the most reflexive, probably, in these settings, in a way that we can learn to acknowledge our emotions. Excuse me, you won't hear me, right? Anthropologists are the ones who are probably the most reflexive in a hospital setting, and I think we really should use that. And the diary writing method of ethnopsychoanalysis offers a very great tool to work with emotions, which I'm using since 20 years whenever I go on field work abroad, but also at home. And thank you very much for speaking up with this topic, because we are all human beings. And when we are in healthcare setting with our research, that there's always emotion there, because this is always, you know, most of the time people go to healthcare facilities because they have health problems. And this pregnant woman also turned out to having a very severe problem and loss in her life. So it's very normal to have emotions there. And I'm totally with you that we even should, when we plan such research, start about thinking and getting, for example, a psychologist to be with us in our research, if this is possible for your universities, for example, like in Brazil, you can have this support, because you will face emotions. And if it's not your own emotions so strongly, it's the emotions of others that might trigger things that you have not even expected to.
Yeah, thank you. I will look that up, that link that you sent. Thank you very much. And it is something to take into account, especially in this field. I'm lucky enough to work with a lot of professionals that have more experience than I do in this type of field. And we are extremely aware of that potential triggers and strong emotions that we might encounter when working in healthcare facilities, especially when it comes to pregnancy loss, pregnancy complications. So yeah, it is something that I felt very strongly about, because I didn't expect to feel that way. It was the first time I encountered that in the field. So thank you again.
Thank you. And okay, let's see, there are any other questions? Okay, then I'll just ask you a question and just break the ice. And I was wondering, thank you again for talking about effective turn and emotions. And I think these reflections are really much important. And we're kind of coming little by little to hospital ethnography. And of course, you know, they always have been there. But at the same time, it's still a little bit difficult to probably theorize them, or at least, you know, using them in a productive way. And I think, of course, you know, anthropology, like more generally, instead of only hospital ethnography, is actually quite full of these revelatory moments in which you all of a sudden realize, because of emotions or because of a particular situation, that you have, you know, taken absolutely the wrong approach about something, and then, you know, the entire cultural world opens up before your eyes. And I was wondering about, you know, the connection between insight and emotion, which is an interesting thing that you pointed out. And working in AER myself, of course, you know, the emotions are something that are always prevalent, and you know, death and sense of loss and desperation is, of course, there. I was wondering if happened to you, or if you have been reflecting about instead of failure when it comes to an emotional insight, in the sense that emotion can actually trigger a knowledge insight, but also on the opposite side of the spectrum, they can also make you fixating upon something that has certain value for you, but instead is actually just a normal example of something that routinely happens into the place. So it doesn't reflect a reality that is out there. So something that is, you know, the tension between emic and etic. So your own perception as an ethnographer and what is outside of you. So I was wondering if you had reflection about it.
Yeah, absolutely. And it is kind of a big question, isn't it? It's I think my take on it is that we need to be extremely honest about where we come from and what our triggers are and what our personal biographies are and how they connect with those emotions in the field. Because as you said, not everyone is going to be moved the same way by the same events. And I think that very clear when we work in these facilities with doctors or healthcare workers that are very used to witnessing pain, physical pain, loss, that kind of situations, and we aren't. And I think our reactions are also field information, but we need to be extremely honest about the complete lack of universality to those feelings and emotions. But yeah, in this hospital experience that I've been having, it's been kind of a difficult thing to navigate, that emic and ethic sort of ambivalence, because I've been basically following healthcare workers, but I'm not a medical doctor or anything related to that, and some aspects of it have been very shocking to me, and so I've been feeling more connected to patients most of the time than to the people that were actually letting me into those spaces. So it is, I mean, we could be discussing for hours on that specific question.
Thank you for this. And yes, I absolutely agree. We could be discussing for hours about this. And I strongly believe that this also talks about the positionality and the reflexivity of which is the topic of today's workshop, about the positionality of ethnographers, but at the same time also the positionality of the people that stand around ethnographers. So what resonates and what instead doesn't, and how we write about it and how we describe it, of course, is also definitely a matter of emotions and what strikes us in the first place. And there are any other questions about this? I saw Margaret had another comment, but maybe let's see if somebody else has a comment before that. Dennis?
Yeah, I find that the whole panel was very fine, a great diversity of perspectives of the way anthropology is contributing to health. Mirko, might I ask that might we say something about, we're going to try to follow up with this presentation with a recording and a discussion with the Society for Medical.
Absolutely, please go ahead.
That?
Yeah, absolutely.
Yes. Well, the last time Mirko had a forum like this, I invited him to host the. I'm the chair of the Society for Medical Anthropology Health Professions Education Special Interest Group, which has just been forming now within the last year. And so we try to bring all kinds of information to our members. We have about 200 members so far in 60 countries of the world. And so when Mirko did his first presentation, we had our members saying, well, we weren't able to make it because we're somewhere else in the world, get the time. And so we posted the presentation up, and then we opened it up for discussion, but it was kind of limited. So this time, Mirko is, we're trying to figure out a way to do this in a more systematic way. So what I'm hoping will happen, Mirko, you can tell me if I got this, how best we can do this. But our intentions are that when this finishes, Mirko is going to provide us the link to the recording, and we're going to create a Google group discussion in the Society for Medical Anthropology Health Professions Education group, and it'll be open to all of our members. But Mirko, is there a way that when I set this up, you're going to be in control of admitting people into the group, right?
I think you just somebody just has to join the community, and that would be able to access the recordings,
the dialogues. And this is only going to go for a limited amount of time. Mirko is going to say how much he can contribute in the conversations. But I welcome other people in this session to do that, especially the speakers, because people are going to be viewing this and may even have comments about your particular pieces of work. So this is kind of an experiment in the virtual dialogue. Mirko, is there a way that you might, when I send out the invite to our members, that maybe you share it with this group if they want to join also?
Absolutely, and because this group has always remained very open, so I share the information for this group through Anthropology Matters, so different listservs. So Anthropology Matters, Anthropology, Medical Anthropology Europe, and the MICE listserv. So I'll do the same, so that everybody could access it.
All right, and so that's what our plan is, and hopefully the technology will allow us to have a continued conversation about all of your work. Yeah, thank you.
Thank you, Dennis, for this. And I have a question. So Rafael asked, is it okay if I read it? Because so there are problems with the internet connection.
I can try to speak and see. I can't have my video on, but I mean, it's not really a question. It's just in the format. I mean, I really appreciate the in-depth explorations of each field site and approaches that all of the speakers shared. And I think it would be really interesting to have a kind of roundtable on themes where we'd have shorter, insights, and then kind of building on each other, kind of conceptual explorations. I think it would be a kind of an interesting kind of take to with perhaps the same people or others. I'm interested in this because I'm both a medical anthropologist and a clinical psychologist working in an ICU unit. So there's so much that I would love to, unpack further with different presenters from today. I really appreciated all the presentation, and I think there's really some kind of key points. So I was saying just around listening and attuning as anthropologists and bringing anthropology insights into clinical space and kind of really getting into maybe some, key ethnographic moments of, how that works out in the, how that unfolds in the clinic when we practice this, I think would be another way to kind of, really build collective thinking amongst participants. So yeah, more of a remark than a question, as we say. But yeah, thank you so much, everyone.
Thank you. That would be actually wonderful to be able to organize something similar. And I don't know if Patricia wants to comment about this, because she also has experience in working inside a hospital setting and working within the cultural consultations. Patricia, do you want to just jump in? Sorry for inviting you to the stage.
Sorry, I was muted. No, that's okay. But I'm always I have different emotions when I hear these presentations, because on the one hand, I think, oh, I'm really not a real anthropologist, and these are fantastic people out there doing these research projects. But at the same time, I mean, it goes back to something that Dennis asked earlier. So, what's your impact, or, how is this affecting things? And I think that's where my position is so different from some of the other people who've spoken today, because I am maybe integrated to a fault within the hospital. So there's a lot of change in identity and maybe a lot of practical impact, like through the cultural consultations. But I think there's difficulty finding that space in between being useful and integrating and finding, creating a space for oneself that makes sense within this crazy organization, which is a hospital, and maintaining some identity as an ethnographer. I'm jealous of people who can just be ethnographers in a hospital. I feel that my role doesn't allow me to do that. So I'm encouraging other people to come and have that role. there was one, I've forgotten now, but there was one comment about, you know, when we were talking, about cultural consultations and needing to, I'm losing my train of thought here, but I think there is a role for, I don't think that you have to train in cultural competence before you can have an impact on it. I think there are other ways to be an anthropologist in the hospital and have an impact on that thing we call, you know, intercultural competence. And sometimes, if I think of myself, sometimes just observing a consultation for some other reason, you can just throw in a little comment, throw in a little different way of thinking about what's going on in that consultation. And I feel that our cultural consultation is actually, some of its more important impact is on that one individual who says, I don't know what to do with this patient. I don't know what to do in this situation. And just throwing out a little, have you thought about this? What do you know about this aspect? Have you asked this question? And that's it, you know, just plant a little seed. And these things can then be tied in later to some more formal training. Anyway, those are the thoughts that have been going through my mind as I listen to all of you, but it's just great. It's very stimulating and encouraging to see the work that's going on out there.
Thank you so much, Patricia, for this. And I just wanted to point out that, as Margaret did probably in the chat, we have been talking about clinical competence and in intercultural competence, and of course there has been right now, but also, you know, it's quite a debate that is still going on about structural competence instead. Absolutely. And the problems that culture has when it comes to our representation within places like hospitals. And I was wondering if any of you want to share, for instance, why using culture in a particular setting like the hospital is still, our identity as anthropologists is still kind of so much tied to the concept of culture that is so kind of unavoidable to use it. Or, and
it's also part of, I mean, I think you have to use it in the sense that that's what people think we're all about, and they want it, right? So somehow I think you have to use it. And then I think this whole notion, like when I think about some of our cultural consultations, I find myself often saying, you know what, I don't really think there is any cultural element here, because a lot of times it is more structural, social, economic issues in the background. And so, but it's an entry because there is this over culturalization of, at least in my case, of communication difficulties. And because a patient has a different color of skin, or because they have an accent, or because they have a different, passport, etc., then it's suddenly, if there's a problem, the question of, is it a cultural problem, just pops into everyone's heads. So on the one hand, that's unfortunate, but it's also sort of a wedge into discussing some of the other issues.
Yeah, the criticism there would be that, you know, culture becomes a way to hide, to individualize, and to hide historical oppression and historical structures of power and so on and so forth. That's an interesting tension. But I think Margaret had a comment about this, so I'll leave the floor to her comment.
No, thank you. It somehow links to this. I would like to encourage the Indian colleague and follow Patricia, because I recently was the anthropologist in an online pediatric emergency simulation project with Pakistan, the US, and me in the middle of the world. And what I pointed out at a certain point, because they were just doing the simulations, and then we had debriefings and focus groups afterwards, that in highly diverse societies, as Pakistan is ethnically wise and India as well, people have a high cultural competency, or at least they are aware, or they deal with diversity from many aspects. I think it could be our role to point this out, instead of trying to develop a training and like, you need to know A, B, C, D, and then you're cultural competent, which we all know from our side that doesn't work, but hospital organizers still think this works. It's more to find out, or to make them aware, what do you already know? And in our Pakistan case, it was, we just asked, how do you deal with this language diversity? And they have the ways to deal with diversity, because they don't have access to technical devices or to professional translators, but they have a way how they deal, and it's emergent situations. So I would like to encourage you and everybody, actually, because I'm in training or trying to engage in all those things since long, stepping away from cultural competency training.
Well, I think it's also, if I can just jump in there, I think also the problem is how cultural, I don't even like, I mean, I hate the term cultural competence. I think it's at best, it would be intercultural, perspectives. But anyway, that training we're talking about, I think it's a shortcut to saying, oh, you need to know. I mean, in the past, it has been a shortcut to saying you need to know what this community has in the way of practices and beliefs and values and whatever. And I like to think that we've moved away from that a long time ago. And I know that's not true in some places, but in many places, I think we've kind of moved on from that. But I still think that, at least in many medical situations, people still expect that that's what anthropologists bring to the table, right? So I have, from day one, I mean, I've been in this hospital for 20 years, and I was like day one thinking, oh my God, there are people calling me up and saying, oh, I have this Nigerian patient, and he won't take his treatment. How should I be dealing with this Nigerian patient? I'm like, I have no idea, but gee, why don't we go and sit down and talk with your patient, and then it's showing about like what questions or what things to explore. So it's more like techniques, and I think that kind of training, that sort of perspective, is what now, anthropologists can bring to this discussion of intercultural competence in healthcare and training.
If I might add, this idea of focusing on individuals and cultural understanding of the clients and cultural consultancies. Once we do enough ethnography of the clinics, and once we do enough ethnography of patient-healer relationships, we then have a perspective on the whole healthcare system that few other people have in the healthcare system. And so over the years, I published along the way on different roles I was in. But I then turned this from not just being an observer and an ethnographer, but to help the organization that I was part of to be better at whatever the goals are. And so in university administration, planning, medical school, all of those things, I view it as directed organizational culture change. And so we're just not consultants on individual cases.
Yeah.
But the accumulation of that knowledge then helps us to give feedback and to be a part in actually the decision making of the organization that we're part of. And so that way we become much more valuable as medical anthropologists in healthcare systems.
Okay, Lavinia?
Yeah, it's actually just to echo what Danis was saying. When I think about cultural competence as, what might be competent as a medical anthropologist who's come from Italy and is working in a UK setting, so it'd be of an insider outsider. It's bringing in like the culture of the hospital rather than of the individual patient. Is
That's
what
right.
cultural,
absolutely.
what cultural underpinnings are the healthcare professionals bring into the patient doctor encounter or other type of encounters that you can find in different. I'm doing at the moment more research on other social care settings coming from a public health perspective, critical public health perspective. So when I think of culture, I also a bit I don't like to think of culture as some kind of baggage that people brings with themselves. So I think there's also something else that we can add as is the dynamic and the relational aspect of, what cultural aspects we decide to bring and use in these encounters, rather than some kind of, luggage that we often pick what we bring in the encounter. So I think it's also like on one side, as Danny was saying, it's not the individual level, it's the structural level that we have a competence in. So the culture of the hospital, etc. But it's also understanding how these things that we call culture is a dynamic exchange, and we can help healthcare professionals to understand that.
Absolutely, I totally agree with you on this, and I think that, but I would say that I think part of that, when I think about my own teaching, it's always focused on raising awareness of the healthcare institutional culture. But I think I think I wouldn't completely agree that people always choose what they bring. I think it's true sometimes, but I think a lot of it is all the unconscious cultural baggage that people bring, the things that they take for granted, the things that are normal, that they consider normal and expected in a given situation or a given institution or whatever. I mean, I see that all the time, whether it's healthcare professionals or social workers or whatever. It's just all the stuff they take for granted. And, and I think that's the cause of so many of the communication difficulties that at least I'm seeing, and so it's kind of shifting the perspective, that it's not looking at the, the problematic cultures of patients,
Yeah, Patricia, I agree. I think choice is not the right term to use. It's that kind of assumptions and take it for granted that we all bring to our exchanges.
And you need to be aware of what you're bringing.
Yeah.
And what you're expecting, to understand why the person on the other side is reacting in a unexpected way, for example.
Just linking to probably the last presentation by Anna is also, I wonder, and this is just something I've never experienced or thought about before, but I think there's also something that probably we can do in terms of emotions. I'm thinking of the role of emotions in this type of exchanges, and I feel like healthcare professionals, for various reasons, and some are probably very good, is about shielding their own emotions and a bit of the kind of hard science researcher that, what do we do with emotions? Nothing to do with what we're doing. But it might be, maybe we also can have a role in trying to understand how we could work with emotions differently in healthcare settings. But this is just something I was thinking, defining the role of medical anthropologists, what we are there for.
Anna, do you want to add something about this?
I was just thinking how one of the things that I've been encountering when navigating emotions in this field is how actually in healthcare, emotions are kind of a problem when it comes to the relationship that, or the work that the medical staff is trying to do. When people cry in the middle of a consultation, or when they feel the need to stop and kind of process, or just to feel their feelings, it's kind of always seen as something to deal with, or something to handle, something to sort of avoid. So I completely agree with you. We should help healthcare workers accept emotions as well, not only as researchers to understand them as valuable information, but also to let them embrace them in their practice, because it is, I feel like it is seen as a problem for their work.
Absolutely, I would definitely have another comment. Rafael, do you want to jump in and try again, or?
Sure, thank you. No, I was thinking back about Dr. Kalindi Sharma's, kind of teasing out of the specific dynamics linked to the location of the hospitals and minority majority culture dynamics. And I think we tend to speak about hospital culture and power of doctors in this sometimes, for us anthropologists, I would say undifferentiated way. And I think it's really important to think about, yes, like Dr. Sharma did, about specific hospitals, and within hospital specific units, specialties bring different kind of, recruitment identity of health workers and of patients, and this plays out in clinical encounters. And so even as we speak, and that's obviously like a structural reading, right, of culture, of discourses on culture. And I think when we talk about structural competency, we also have to pay attention to those more tease out those specific dynamics. So I'll let Dr. Sharma speak, because I think maybe that's building on this or expanding on this.
Thank you, Rafael. May I? Okay, so there's just a small detail that I missed out. So and it has more to do with how these arrangements are also resonated in the policy. So we have a very strict policy when it comes to licensing the medical practitioners. As I told you earlier also, that we have the Medical Council of India, that is kind of like the appellate authority that oversees all the medical practitioners. And then we have these allied professionals in which anthropology is not included. So we have, after MCI, we have the RCI, which is the Rehabilitation Council of India, in which we have occupational therapists, speech therapists, clinical psychologists, and we have psychiatric social workers and other specialists who are qualified to sit in the clinic. So pretty much when it comes to anthropologists, we have kind of a floating position in the hospital where we have to constantly negotiate with our position, our positionality in the hospital, but we have to also constantly remind people that we do not have the necessary license to sit in an OPD or an outdoor clinic and deal with patients and carry out consultations independent of in the absence of any other clinician. So we always are people that need to be chaperoned along with some individual who probably has an MCI number or an RCI number. So even at the policy, you can see the hierarchy being reflected again and again, and that poses additional challenges for us as anthropologists, as medical or social or cultural anthropologists. Our role as an anthropologist is never clearly defined, and therefore we get relegated to researchers and community outreach program, because recognition of our contributions in the hospital setting means that we need to be constantly engaged with the idea of clinic and with the idea of patient consultation, which we may be very wary of, given that when it comes to, at least in case of mental health, the Mental Health Care Act of India is extremely stringent, and it's more, it always facilitates patients over the clinician. So it's for this reason that I also wanted to point out this detail, that these are some of the challenges that we deal with on a day-to-day basis. So we have to constantly remind everyone to take into cognizance the necessary licenses that we may not have as anthropologists. Thank you.
Okay, thank you again. And I think that was the last comment, I think, because we hit 6 p.m. chat. And so thank you again for the presenters. And it was really, really great. It was a great discussion. We touched upon exceptional states, waiting rooms, culture, and emotion. So we really traveled around to the different kind of positionalities that are taken by ethnographers within hospitals. And that was really interesting to see how the different positionalities actually have an effect upon our role and our possibility to negotiate a role within a complex institution like the hospital. I put in the chat also a link through a LinkedIn group, which is the AAN Applied Health Club. And within 2 days, there's going to be a discussion about similar topics in which I and Margaret are also going to present a part of our experience as teachers within a hospital setting in continuous education with both physicians, nurses, and different kind of healthcare professionals. And that would be also another place where to continue this kind of discussion. And of course, I'll keep you all posted about when is the next hospital ethnography meeting. And I hope to see you there soon. Thank you again for coming here today.